Hello, pathology friends. How are you? Good morning, good afternoon, or good evening, whatever may be the time you are seeing this video. In this video, I'm thinking of doing a update in soft tissue sarcomas. This will be in three parts. Part one will cover 2020 WHO classification of soft tissue tumors and its updates. Part two, I am thinking of doing the molecular surrogate markers of IHC, which is an exciting area now. And third part, it will be a very quick slide seminar. And I did this discussion with Kolar Medical College and Chettinad Medical College recently. And these are recordings of those presentations. And I hope you will enjoy it. Thank you very much. See you. Bye bye. Sarcoma means swelling made up of fleshy tissue. And sarx means flesh and oma means swelling. You all know oma is swelling. And the latest WHO classification has more than 100 types and subtypes of soft tissue tumors under its belt. And the main treatment of sarcoma is surgery, and the radiation and chemotherapy depends upon the other factors. And the chemotherapy, previously it's only cytotoxic agents. Now we have targeted therapy. So whenever you say chemotherapy, is it cytotoxic agents or targeted therapy? We have to specify. And pathologists play a very vital role in soft tissue tumors because the recurrence rate depends upon the margin status, and we are people who confirm the margin status. Okay, so the recurrence of any tumor depends upon whether it is there in the margin, and we have a very critical role in assessing the margin. And the metastasis and 5-year survival depends upon histological type and grade, where again we play a very important role. And the most recently appreciated role from pathologists is molecular classification, where we can use the targeted therapies. Okay. We will talk about it more, and we also play in that role. In the follow-ups of soft tissue tumors, 20 to 30% of them they recur, and 30 to 50% of them will go for metastasis. And the 5-year survival of a high-grade sarcoma is 55 to 75%. And probably these numbers will be changing because of the targeted therapies. These are all the numbers available right now. So in short, the pathologists play a very vital role in the diagnosis, in the prognosis, and in the theranosis. That is the terminology where we help the clinicians by telling what targeted therapies can be given for a particular tumor. Biologically, the soft tissue sarcoma is divided into, soft tissue tumors are divided into benign, intermediate, which is locally aggressive and rarely metastasized, and malignant. This is very, very essential because the recurrence rate and the metastasis depends upon these findings. The local growth, usually in benign, it is non-destructive. If you see the examples, you will be able to correlate them very well. For benign, take a simple lipoma, it is a non-destructive lesion. There is no recurrence and metastasis, and the treatment is local excision. Whereas a desmoid tumor fall under intermediate category, which is locally aggressive. It is having a destructive growth, means infiltrative growth. Even though it's benign, the margins are going into the adjacent structures, so it's a destructive growth. So the recurrence is there in intermediate category. This recurrence is mainly because of the infiltrative margins. It is because of incomplete removal. Even though we put for wide excision, grossly the surgeons cannot see the extension of tumor into the adjacent structures, and so they may leave some of the tissue, tumor tissue, in the patient, and that may recur. Whereas the metastatic rate is nil in cases of locally aggressive intermediate tumors, and the treatment is wide excision. There are some tumors like desmoplastic, so DFSP. Here
It's a destructive local growth, the recurrence is present, and the metastasis is also there. Up to 2%. The DFSP can metastasize up to 2%. So they need wide excision with the follow-up. Whereas in malignant tumors, the growth is destructive, recurrence is present, and metastatic rate is high. That's why we have to go for radical excision from adjuvant therapy. And leiomyosarcoma is the best example of malignant tumor. So this table is very, very important. And I thought whenever it is important, I want the participant to take a snap of it. So you will see this selfie sign. That means you have to take a snap of that slide. Coming to the part 2, how to approach the soft tissue tumors. Soft tissue tumors are mainly primary or secondary. We are going to talk about only primary in this discussion. And as I told before, it's divided into benign, intermediate, and malignant. And how we determine this? By looking at the light microscope and by doing ancillary studies. In the light microscope, we see in the low power and high power. In the low power, we see the pattern. And I will be talking about the pattern in a minute. And then junction of the normal and tumor, whether it is pushing or infiltrative. Most of the soft tissue tumors doesn't have capsule, but they are all well circumscribed in a benign end, whereas it will be infiltrative in a malignant end. And then we have to see the cellularity of the lesion. Is it hypercellular, hypocellular, or both hyper and hypocellular? We have to see the stroma in the background, and we have to see the margin status in the low power. After finishing those things in low power, we go to the high power and see the cytological ATPR, what we call it as pleomorphism. And we have to look for mitosis and apoptosis, and we have to count in 10 high power field, or nowadays they are calculating it in millimeter squares. And then we have to look for necrosis and hemorrhage. This necrosis and hemorrhage is already noted in the gross examination, but we have to confirm it under the microscope. Coming to the ancillary studies, the exam going PGs, we have to always remember histochemistry first, even though I will be talking very less about or nothing about histochemistry, but you have to talk about histochemistry first, followed by IHC. And then other additional studies are karyotyping, molecular studies, which includes genomics and proteomics. When you are comparing the cells, normal cells, to determine the pleomorphism, you have to compare it with the normal cells. And the new thing, or whichever I come across now, is we have to compare it with the endothelial cells to see the pleomorphism. I will show it to you in a minute. And this needs a snap at this time. So I told you the endothelial cells has to be compared. This is an endothelial cell in the stroma of a tumor. You can see the flat cells with some hobnailing is there, but they are very flat. And whenever the tumor is made up of cells similar to that, that's a benign tumor. Okay, this is a hemangioma where the tumor cells or tumor cells forming the blood vessels are very similar to tumor cells in the normal. And this is a glomus tumor. You can see the perivascular location of these tumor cells, and these cells are larger than the normal endothelial cells, and that's why it is known as, if you want to grade it, it's grade 2, and this is grade 3, which is very pleomorphic. So by comparing the endothelial cells, the ATPR can be grade 1, grade 2, and grade 3. Grade 1 is mainly by similar to the benign looking endothelial cells, whereas the grade 2 is more larger cells, and whereas grade 3 is much more pleomorphic cells. And this comparison with endothelial cell, it might have given in many textbooks. I learned from Gerard Gardner, and many of you may be knowing. I have given the Twitter handles. And by the way, these are all my communication method to freely talk to my friends and my juniors. In the Twitter, my handle is at @rdpatho. In Facebook, it is Swaminathan Rajendran, and I have my own channel in YouTube, and Dr. S. Rajendran is the name. And these three people I love regarding soft tissue tumors. See, we used to have mentors, but now I think the pathology is advancing so much. For every division of it, you should have very good mentors. Gerard Garner, Jason Hornick from Boston, and Elizabeth Montgomery, madam. She was in John Hopkins, but now she moved to Miami. So these are all the three wonderful people from whom I learned a lot by listening to their videos. I know them very well, but they don't know me. And it is their problem. It is not my problem. If you know somebody, you all know Modi, but Modi doesn't know you all. And that is Modi's problem. And that's how we have to approach the life. So I thank these three beautiful people for educating me in soft tissue tumors. So I talked about the patterns. These are all the 6 patterns you have to remember. Fascicular tumor means they are all arranged in long bundles or intersecting bundles. Okay, spindle cells with indistinct cell border, moderate amount of eosinophilic cytoplasm. Why I say moderate amount of eosinophilic cytoplasm? Because the nuclei are separated. Okay, even though the border is indistinct, depending upon the distance of the nuclei, in between the nuclei, you can guess the amount of cytoplasm. So this is a fascicular tumor. And this is a myxoid tumor where you see hypocellular, largely myxoid, means more bluish, watery material. So this is a myxoid tumor. And these are epithelioid tumors. The cells look more like epithelium. Oid means resembling. Here, these are all mesenchymal cells that look like epithelial cells. That's why they are known as epithelioid pattern or epithelioid tumors. And here, as the name indicates, these are round cell tumors. Here, the cytoplasm is less because the nuclei are touching each other or overlapping each other. That's how you have to know the amount of cytoplasm whenever the cell border is indistinct. So these are all the round cell tumors. And these are pleomorphic tumors. You can see many giant cells, mononuclear and multinuclear giant cells. And when do you call definition of pleomorphism? Take the smallest cell and take the largest cell. If it is more than 3%, it's pleomorphic. Again, it is, I learned this from Gerard Gardner. So that's the definition of pleomorphism. And lastly, vascular tumors, where the tumors form a lot of blood vessels. Okay, so these are all the 6 patterns you have to know in soft tissue tumors. And this is a composite picture where you see all the 6 patterns. I request the audience to take a picture of this. I think selfie is there. So these are all the conventional teaching of soft tissue tumors. With that background, I have to go to updates in soft tissue tumors. Let us first start with the WHO 2020 classification. There are 12 major divisions in the soft tissue tumor classification. In all WHO classification, whatever may be the organ, first you have to understand what are all the major headings in that classification. In soft tissue tumors, it is tumors of adipocytes, fibroblastic and myofibroblastic tumor, so-called fibrohistiocytic tumors, vascular tumors, perivascular or pericytic tumors, smooth muscle tumors, skeletal muscle tumors, gastrointestinal stromal tumors, chondro-osseous tumors, peripheral nerve sheath tumors, tumors of uncertain differentiation, and undifferentiated small round cell sarcoma of bone and soft tissue. These are all the major headings you have to remember. And in each heading, you have to know the conditions that are benign, intermediate, and malignant. Remember that table I asked you to take a picture of it? That will help you to determine whether a tumor is benign, intermediate, or malignant. So 12 into 3, at least 36 tumors you have to remember. For example, adipocytic tumors, benign is lipoma, intermediate is atypical lipoma, and malignant is liposarcoma. Like that. I'm making it very simple, but it is not that simple. But the concept is know the major headings and know one member at least in the benign, intermediate, and malignant categories. And with that background, I'm going to show you all the tumors. Please believe me, I'm not going to bore you by reading all these things, because these are already given in my notes. So whenever you see fatty tumor, you see whether it is benign, intermediate, or malignant. When it is malignant, is it well differentiated, dedifferentiated, myxoid, pleomorphic, or myxoid pleomorphic? Okay, this is how you have to approach. This is for adipocytic tumors, and I'm not asking you to take pictures of them, because I have given these things in the in my notes. Fibroblastic and myofibroblastic is the biggest criteria in the 2020 WHO. So again, benign, intermediate, and intermediate itself is having locally aggressive and rarely metastasizing, and then malignant. And this is for fibrohistiocytic tumors, benign, intermediate, and malignant. For vascular tumors, benign, intermediate, and intermediate, locally aggressive, and rarely metastasizing, and malignant. Pericytic tumors, benign, intermediate, malignant. Smooth muscle tumors, benign, intermediate, and malignant. Why I'm repeating this benign, intermediate, and malignant? Because you have to make that embedded in the white matter of your brain. Skeletal muscle tumors, benign, malignant. Gastrointestinal stromal tumors, it's no benign, intermediate, malignant, because they are all malignant potential. So they have to be divided into low grade, low malignant potential, intermediate malignant potential, and high malignant potential, depending upon the size, mitosis, and location. Okay, in the stomach we have different criteria, in the duodenum we have different criteria, but these criteria you have to remember, three of them: size, mitosis, and location. Chondro-osseous tumors, again benign and malignant. Peripheral nerve sheath tumors, benign, intermediate, and malignant. And tumors of uncertain differentiation, benign, intermediate, locally aggressive, intermediate, rarely metastasizing, and malignant. Undifferentiated small round cell sarcoma of the bone and soft tissue. This is previously known as Ewing sarcoma, but now it has three more members: round cell sarcoma with EWS or non-ETS fusion, CAC rearranged, and BCAR rearranged. We will see them again and again. So the summary of the WHO 2020, you please remember these 12 subtypes. Now we are moving to next one. What are all the changes? And before that, I just want to ask, Madam, is there any questions, Madam? Kalani, Madam?
No questions, sir.
Super. I request the attendees to feel free to ask me questions if you are not able to understand anything, or if I am going too much too fast, you please request your questions and I will answer them and we will proceed. So what are all the changes? Again, there are 12 major headings and there are 23 changes in the WHO 2020. Remember, 2020 has 23 changes. And what are those changes? There are 12 new entities. One entity was renamed, 4 of them are reclassified, and 6 of them are deleted. If you have not read the previous 2013 4th edition, you don't have to worry now, because you are starting a new knowledge building, so you don't have to worry about it. But in the exams, they may ask you, what are the changes in WHO 2020 soft tissue tumors? So you have to remember 23 of them, and this is the breakdown. And let us see. In adipocytic tumors, there are 2 new entities. One was reclassified and one was deleted. In the fibroblastic and myofibroblastic, 3 new, 1 reclassified, 1 deleted. And so-called fibrohistiocytic tumor, that malignant fibrohistiocytoma was deleted. In vascular tumors, 1 was added and 3 were deleted. In smooth muscle tumors, 2 new entities. In skeletal muscle tumors, 1 of them is reclassified. In peripheral nerve sheath tumor, 1 of them are renamed or reclassified. And tumors of uncertain differentiation, there is 1 new entity. And in undifferentiated small round cell sarcoma of the bone and soft tissue, there is 1 reclassification and 3 new members in that group. So if you add all these numbers, it will come into 23. And I want to take you a snap of this just to tell you what are the changes happening in each major headings of the soft tissue tumors. And let us now see the new entities and what are all the changes in these tumors. In adipocytic tumors, atypical spindle cell or pleomorphic lipoma, ASPLT, is a new entity along with pleomorphic myxoid liposarcoma. Previously, we had pleomorphic liposarcoma, we had myxoid liposarcoma, but now they included pleomorphic myxoid liposarcoma, where in the same tumor you see myxoid areas and the pleomorphic areas. And the extrarenal angiomyolipoma is shifted to uncertain differentiation, and it is known as PCOMA. You all know perithelial tumors. So that PCOMA, AML belongs to that PCOMA. And the extraadrenal myelolipoma was deleted from the 2020. Take a selfie of that. So this is the tumor. What I made up all this history depending upon the prevalence. Okay, this is more common in this entity is more common in middle-aged males and usually happens in the extremities. It has a lot of atypical. These are adipocytic tumor. Okay, atypical spindle cells, and they show adipocytes, and you may see in high power lipoblast, and some pleomorphic cells are there. When you compare the smaller cell and the larger cell, it is more than 3 times enlargement, and the background is more myxoid or collagenous matrix. Here it is more of collagenous matrix, whereas here it is myxoid matrix. And when you do immunohistochemistry, CD34 and S100 are positive with the loss of RB gene, but MDM2 and CDK4 are negative. Because they are molecularly negative for liposarcoma markers, these are now known as atypical spindle cell or pleomorphic lipoma. The recurrence rate of them is high. That's why we have to differentiate this from lipoma. But there is no chances of metastasis or dedifferentiation. So they belong to more intermediate category of lipomatous tumor. This is one of the new entity in the lipomatous tumor. The next tumor, as I told you before, it shows admixture of more classic myxoid liposarcoma and pleomorphic liposarcoma. And again, they are negative for MDM2 and CDK4. S100 protein may be positive or negative, and they are the pleomorphic myxoid pleomorphic liposarcoma. So it is like a combination of both myxoid and pleomorphic liposarcoma. It's very common in young girls, okay, and more common in the mediastinal mass, mediastinal. Okay, so that you have to know. Coming to the fibroblastic and myofibroblastic tumors, angiofibroma of soft tissue, UWSR1, SMAD3 fibroblastic tumor, and superficial CD34 positive fibroblastic tumor are the new entities. Acral fibromyxoma is moved here from the uncertain differentiation, and the calcifying fibrous tumor was deleted. So when you are talking about the tumor entities, some of them you can make the diagnosis by H&E itself. Some of them need IHC, and some of them need molecular, new surrogate IHC marker or molecular findings that you have to remember. For example, angiofibroma, we will be seeing it in a minute. You can diagnose it in H&E. Whereas superficial CD34 positive fibroblastic tumor, you cannot make it on the H&E. Okay, you may see the superficial cells with a lot of pleomorphism, and but you have to do the CD34, and it has to be positive to call it as superficial CD34 positive fibroblastic tumor. Similarly, to call it as EWSR1 SMAD3 fibroblastic tumor, you have to do this molecular workup. I hope you understand. In the H&E, you form the differential diagnosis, and then you do the IHC markers and the molecular workup, and depending upon the finding, you give the name for the tumor. Take a picture of this. So this is a tumor that's very common in the middle-aged females, more near the major joints in the extremities. And microscopically, they show bland, uniform, short spindle cells with a myxoid or collagenous background. And you can see a lot of small, thin-walled branching blood vessels. And those branching blood vessels are highlighted by the CD34 stain. And you can appreciate more the spindle cells and the vascular. These are fibrous cells, so it's fibroma, and these are all blood vessels, so they are angio. So when you combine both of them, they will become angiofibroma of soft tissue. This tumor, which is very common in female, middle-aged, with extremities, it shows hypo and hypercellular areas, central hypocellular areas, which are more made up of collagen, and the peripherally fascicular pattern of hypercellular areas. And these tumors are ERG positive, and all the other markers are negative. You know, ERG is a molecular marker of endothelial cells. But this is one of the tumor where non-endothelial cell tumors can also be ERG positive. And so the diagnosis in this is, when you do molecular workup, they all will show EWSR1, SMAD3 positive. And so they are known as EWSR1, SMAD3 positive fibroblastic tumor. This tumor, this is the skin, dermis, and the tumor is mainly in the subcutaneous tissue, and it shows highly pleomorphic. Okay, previously we used to call it superficial malignant fibrous histiocytoma, and they express CD34 very nicely, and cytokeratin can also be positive. This is the CD34, and you can see better the tumor location in the subcutaneous tissue. So this is a superficial tumor that is CD34 positive. So it is known as superficial CD34 positive fibroblastic tumor. They will show a lot of atypia, but the mitotic rate is less in this condition, and they are very common in the lower extremities in males, middle-aged males. Fibrohistiocytic tumor, the only deleted tumor is malignant fibrous histiocytoma. There is no more malignant fibrous histiocytoma in the soft tissue tumors. They are, when you look into them carefully, they belong to, or they fall into other categories. For example, what we call the myxoid MFH is now known as myxofibrosarcoma. Inflammatory MFH is like inflammatory variant of dedifferentiated liposarcoma. Okay, the new molecular markers are helping to distinguish specific tumors from this waste basket diagnosis. Previously, this is like a waste basket diagnosis. Whenever all the ISC markers are negative, and when they show high-grade nuclear features and possibly some histiocytic markers positive, we used to call them malignant fibrous histiocytoma, but that terminology is deleted now. Take a selfie of this. Now going to vascular tumors, the new entity is anastomosing hemangioma. The terminology is angiomatosis, polymorphous hemangioendothelioma, and giant cell angioblastomas have been deleted. And take a picture of this. And this is renal tumor. Okay, the history, it is more common in male, middle age, and it can more commonly seen in the kidneys and in soft tissue. They show this is a well circumscribed tumor. You can see a lot of blood vessels that are interconnected with each other. So they are all anastomosing blood vessels, and you can see it in high power. They show hobnailing, and some of them may show hyaline globules in the cytoplasm. And here you can see darkly stained lymphocyte-like cells. But when lymphocyte-like cells are seen in clusters like this, you have to think of extramedullary erythropoiesis. And here the terminology clarity is, whenever you see RBC precursors, it is erythropoiesis. WBC precursors, it is myelopoiesis. When you see RBC, WBC, and megakaryocyte precursor, then only you have to call it hematopoiesis. Okay, and this is a tumor that is more commonly present with extramedullary hematopoiesis, and the name of the tumor, as the description says, it is anastomosing hemangioma. It's a H&E diagnosis. Coming to smooth muscle tumors, there are two new entities, EBV associated smooth muscle tumor and inflammatory leiomyosarcoma. In the skeletal muscle, the ectomesenchyma now moved from peripheral nerve sheath tumor. They thought previously it is more like a neural, but now the muscle markers are positive and molecularly they are more related to skeletal muscle. So they moved to ectomesenchyma into the skeletal muscle tumors. And these rhabdomyosarcomas, they mainly classified as embryonal alveolar pleomorphic and spindle cell and sclerosing. In the new entity of spindle cell and sclerosing, there are three subtypes: congenital spindle cell RMS with VGLL2 change, MyoD1. I read it as MODI. Okay, it is not MODI, it is MyoD1. Mutant spindle cell sclerosing RMS and intraosseous spindle cell RMS. And whenever there is classification like this should have some effect on the patient. For example, these three types, the congenital spindle cell RMS with the VGLL2 change, it is having a favorable diagnosis. Whereas the intraosseous spindle cell rhabdomyosarcoma is a very aggressive tumor. So clinically, they are very different and molecularly, they are very different. That's why they have put it as a new subtypes. Take a snap of this. So let us see the tumors. It's a 25-year-old female with multiple liver masses. This is a right hepatectomy. 1, 2, 3 tumors are seen. And there's a history of renal transplant. The H&E shows fascicles of spindle cells. It looks like a leiomyoma. Okay. And even IHC, SMA positive and EBER positive. In addition to SMA, EBER is also positive. And EBER should be negative in a classic spindle cell leiomyoma, isn't that? So that's why this is a EBER-driven tumor in immunosuppressed people, and that's why it is known as EBV-associated smooth muscle tumor. History of immunosuppression, either HIV or organ transplants or chemotherapy, is very, very essential for this smooth muscle tumor to be named as EBV-associated smooth muscle tumors. They can occur in organs like liver and kidney and as well as in the soft tissue. This tumor shows eosinophilic spindle cells, but a lot of inflammatory cells are also there. And usually they are present in the extremities and they are SMA diffusely positive. But there are a lot of inflammatory cells. So that's a new entity named as inflammatory leiomyosarcoma. Without without IHC, it's very difficult to differentiate them. Previously, some of them might have been called as inflammatory myofibroblastic tumor or inflammatory malignant fibrous histiocytoma. But since SMA is positive, and now it is reclassified as inflammatory leiomyosarcoma. There's another tumor in the peripheral nerve system. Okay, this is one of our case. So I'm lucky enough to get the gross picture. This is a 46-year-old male with a 4.8 centimeter right cervical mass. There is no history of melanoma because after seeing the gross picture, we asked the history of melanoma. There is no history of melanoma. And microscopically, it shows spindle to epithelioid Schwann cells with a lot of melanin pigments, and they are positive for S100, SOX10, and HMB45. Okay, they look like melanoma, but the location is more peripheral nervous system. And in these cases, the differential diagnosis is melanotic schwannoma, which is a old terminology. The new terminology is malignant melanotic nerve sheath tumor, because when you say schwannoma, it is a benign entity, but these may recur and these may metastasize rarely. That's why it is now known as malignant melanotic nerve sheath tumor. And they have a very classic molecular loss of PRKR1A. Okay, these are all very difficult. Don't try to memorize them. Okay, just keep them in your mind. Just know there is a marker that is lost in malignant melanotic nerve sheath tumor. And when you see 2 or 3 cases, then you can understand by yourself. And remember, one of my mentor, Dr. Jason Hornig, he told whenever there's a new marker or new name to be remembered, the easiest way is put PRKA or IA as your lock in your cell phone. Just keep it for 1 week. Okay. PRKA or IA or PRKA or 1A. And then if you do it for 1 week, you will remember automatically. Next week, you change to another marker. That's one of his ideas to remember the most difficult markers or new names to be remembered. Now you can appreciate more the melanin pigments and the epithelioid cells. So that's a change in peripheral nerve sheath tumors. In the gastrointestinal stromal tumors, there is no terminology change, but the previously mitosis was counted per 10 high power field. Now the mitosis is counted per 5 millimeter square, which is equivalent to 20 to 30 high power field in a standard microscope. But there are a lot of methods to calculate this. In my YouTube video, I have one of the videos where I mentioned how to calculate the mitosis per millimeter square. Please refer that. We covered the renaming in the peripheral nerve sheath tumors. In the uncertain differentiated soft tissue sarcoma, there is a spindle cell neoplasm that showed N-track rearrangement. Okay, and as I told you, without doing this molecular, you cannot brand it as a N-track rearrangement. It's a spindle cell neoplasm, and because of this molecular change, we call it as N-track. Okay, take a photo of this. And they are more common in young boys, males, and they are present in the extremities. They look like fibroblastic tumors, but they are positive for S100 and CD34. Whenever there is a fibroblastic benign appearing tumor that are positive for S100 and CD34, do a pan-track marker, and pan-track marker will be nicely positive in this tumor, and that's why it is named as N-track rearranged spindle cell neoplasm. Why it is important? We have medicine for this target. That's why you have to diagnose these tumors. Coming to the last change in the undifferentiated small round cell sarcoma, previously we put it as Ewing's. Now it is classified as undifferentiated small round cell sarcoma of the bone and soft tissue. And in addition to Ewing's, there are 3 more entities. Round cell sarcoma with the EWSR1 non-ETS fusion. In Ewing's sarcoma, it is ETS fusion. Then CAC rearranged sarcoma and sarcoma with BCAR genetic alteration. BCAR genetic alteration sarcomas. Okay. So these 3 tumors, we will be talking more and more of them during this discussion. So by the end of the discussion, you will have a very clear picture of them. Take a selfie of that. And this is the HNV view of all the 4 undifferentiated small blue cell tumors. Okay, it's very difficult to differentiate whether it is Ewing's or CAC arranged or BCAR alterations. You cannot tell them by looking at the HNE. But this thing, I have to thank Dr. Karen Pinto. I took it from her Twitter cartoon, and she made it very nice. There are 4 types, as I told you: the undifferentiated small round cell tumors, Ewing sarcoma, CAC rearranged sarcoma, round cell sarcoma, non-ETS, and sarcoma with the BCAR alteration. Why we have to know them? Because the CAC and non-ETS, they have a poor prognosis. They may not respond to chemotherapy, whereas Ewing's and BCAR alteration, they will have a very good prognosis and they respond to treatment very well. And they have their own molecular signatures and some surrogate markers. There is a new marker called as NKX 2.2. Okay, this marker is positive in Ewing sarcoma. Remember, in Ewing sarcoma, we used to say CD99 fishnet-like positivity, and then FLY1, that nuclear positivity, but those can happen in other tumors also. Whereas in NKX 2.2, it's one of the transcription markers that is positive in the Ewing's sarcoma. That's one member of the small round cell tumor. In CAC rearranged sarcoma, there is another marker called ETV4. We will be seeing the pictures of them. Okay, ETV4. In BCAR arranged, as the name indicates, we have a BCAR marker for BCAR. And then the non-ETS, we don't have a very specific marker, but in addition to NKX 2.2, they will have muscular and neural markers. Okay, desmin myogenin, MyoD1, S100, SOX10 positive. Whenever you see a small cell undifferentiated sarcoma that are positive for muscle markers, neural markers, and NKX2.2, that belongs to round cell sarcoma, EWS or non-ETS. Take a selfie of this. So that brings the new changes in the WHO and new entities in WHO.